Welcome to tonight's class on gut health. Thanks for being here. To those who are live, my name is Megan Ellison. I'm a registered dietitian nutritionist and a certified diabetes care and education specialist. And hopefully you joined us for part one. If you missed part one, that's okay. You can certainly go back and watch that recording. You can still participate in this class. Some of the information you might want to go back and review from part one, because we're going to get a little bit more detailed tonight. So let's get into it. We've got quite a bit to cover. We're going to go over what we covered in part one. We'll dive more into IBS, IBD, a little bit, IBS mimickers. We'll talk about allergies, intolerances, sensitivities, so more food related things. And then a little bit on FODMAPs and fiber, and then a bunch of resources for you. So you will get these slides from today. We are in webinar mode, so I can't see you or hear you, but you are welcome to put any questions in the Q&A, and I will occasionally check that. And then after today, Stilly Valley will send you a recording of the class and the slides, so you will have all of those resources. So just so we're all on the same page, this is educational. This is not meant to be medical. I don't know your specific condition. I am not your dietitian. Maybe I am for some of you. If I am, hello. But this is really meant to be like a general class thinking about, what could potentially be going on with your own gut health, helping you do some of your own sleuthing, and thinking about things to prepare you to go in to meet with your specialist, whether that's your gastroenterologist or your psychologist or your dietitian or your primary care provider. So just a little bit more lingo and info and things that maybe you haven't even heard of that might fit your situation if you're trying to figure out what's going on with your gut health. So thank you to Stilly Valley Health Connections. That is who you registered through. They are sponsoring this series and a bunch of other wellness classes. We do in-person cooking demos at their teaching kitchen in Arlington in the Smoky Point area. So hopefully we'll see you at a future class if you haven't taken one of those in yet. They're a lot of fun and you get to taste the sample, which is great. So let's check in from part one. Hopefully, if you are over the age of 45, you have had your colonoscopy or you are getting it scheduled, and earlier if you do have a family history of colon cancer. Some of you may have done this transit check to see if you are FOS or full of stool. And if that's the case, maybe with corn or something that you could see in your stool easily, ideally that would be through your GI tract from the time that you eat it to the time you're seeing it in the toilet bowl in 36 hours or less. Typical is right around about a day. And so if it's a lot longer than that, then you may be really backed up. Even though you are potentially having a bowel movement every day, you could still be full of stool. And I would consider that like a constipated situation where we would want to move things through a little faster. So if you did that check, make a note of that timing. Maybe some of you kept a symptom journal to try and start sleuthing through connecting your symptoms when they happen to your situation, like whether that's stress or potential foods that you've been eating, or behaviors like exercise, for example, with aerophagia, taking in a bunch of air. Slowing down and chewing well. This is a hard one for a lot of us in this busy, fast-paced culture we live in. Listening to your fullness cues so you're not going past those cues and then potentially causing more issues, especially with like reflux and heartburn. Diaphragmatic breathing we talked about, both for helping you to get into the rest and digest side of your parasympathetic nervous system, so that rest and digest mode opposite of fight or flight. And also to get into that pelvic floor. And pelvic floor, I tell you that screening for potential pelvic floor questions. Some of you may have filled out that cozy and screen. And if some of those items came up as being red flags, you may want to consider talking with your primary care provider or seeing a pelvic floor specialist. And that would be a physical therapist who is specialized in pelvic floor therapy. Maybe some of you started reading labels and avoiding things like sugar alcohols or monk fruit. Some of you may have needed some adjustments in the timing, giving yourself time to have a bowel movement, ergonomics. So like that sitting, getting your knees up a little higher. Maybe you have a squatty potty, or maybe you have a stool now in the bathroom that could be helping. Fluids, fiber, movement, like daily moving your body, stretches, things like that. Decreasing risk of arophagia. So I already mentioned this with slowing down and chewing well, good dental hygiene routines, reducing things that can cause GI issues like smoking, alcohol, other substances. And then I also, besides the cozy and screen, I also gave you a bloating quiz, which is really like nutrition. It's helpful for me. Like it's kind of more nutrition related. Like it's looking at things like, are you constipated and full of stool? Or do you have potentially a carbohydrate intolerance? Is there something else going on with bloating that could be related to like a bacterial overgrowth, for example, like small intestine bacterial overgrowth, which we'll talk about today. But that is a tool that I sometimes use with my patients just to kind of get a sense of like, how are they responding in different situations to different kinds of foods? And that can give me a clue as to like what might be going on here and a place to kind of start. So you can always share that with your dietitian if you already have one and you're working on GI stuff. Because there's a lot of reasons for bloating. So you could be bloated because you are backed up and full of stool. You could have sensations of bloating because of that gastroparesis or that slowing of the gastric emptying or the stomach emptying. Functional dyspepsia, or what we kind of consider like, the classic like upset stomach. Aerophagia, the swallowing of the air. There's something called abdominophrenic dyssynergia, or APD. You would also see a pelvic floor specialist who is a physical therapist for that as well. And that has to do with some disconnect between your brain and your diaphragmatic muscles. So that is a real thing where some people just get like an over relaxation of the diaphragm in that abdominal area in response to eating, sometimes in response even to liquids, where you just all of a sudden get this relaxing and the body is like almost overcompensating to allow space and room for things to come in. Small intestine bacterial overgrowth, SIBO, and intestinal methanogen overgrowth, EMO. We will talk about both of those today. And those can be significant causes of significant bloating and pain with that as well. Carbohydrate intolerances. So if certain foods are not getting broken down and then they're getting all the way to your large intestine and then fermenting because your bacteria love carbohydrates, that can be a thing. Pancreatic insufficiency, if you have lack of enzymes to break down foods, and that could be carbs, proteins, or fats. Fat malabsorption, so again, that could be related to either low pancreatic enzymes or to a struggle with your gallbladder. Or if you don't have a gallbladder, where you don't have that little reservoir of bile that can help break down and emulsify your fat in your food, then you don't have as much wiggle room with how much fat you can have in one sitting. So figuring out like kind of what your tipping point is can be really helpful so that you can keep that total fat gram under a certain amount so that you're not having symptoms. And then celiac disease, another related malabsorption that goes with that. For example, oftentimes in celiac, there's a secondary like lactose intolerance until the gut villi regrow and heal and are able to make some of those enzymes again. So lots of different causes of bloating. And it's a very common thing. If it is not, if it's transient, like if it happens a couple times a month, no big deal. But if it's happening all the time for you, it's definitely something that you want to talk about with your primary care or your dietitian. Or if you have a gastroenterologist, that's fantastic, because it can indicate something else going on, like one of these things here. Okay. So the big topic, IBS. It's IBS Awareness Month. It's April. So we're in the gut health world, we're all thinking about IBS. But it also just is a big topic because so many people are affected by IBS. It's now classified as a disorder of gut-brain interaction, which is an umbrella term for both IBS and some other things like functional dyspepsia. And here's the Rome criteria, or basically what is the kind of international scientific standard criteria for diagnosing IBS. And I'm actually going to read it. So it's recurrent abdominal pain on average at least 1 day a week within the last 3 months, associated with 2 or more of the following. So that's pain with defecation or with changes in frequency of stool, and or also associated with a change in form or appearance of stool. So again, it's within the last 3 months with symptom onset at least 6 months prior to diagnosis. So we don't want it to just be a short-term thing where you get like, you know, a little bug and it passes through you. Maybe you have some pain and diarrhea and then it's gone. This is an ongoing thing. I was going to say syndrome, but really like a lot of people in the gut health world are questioning whether we should be calling it a syndrome. That's kind of for the, you know, the science nerds to figure out. But regardless, like this is the criteria. So you can see how that is pretty generic, right? It's not super specific. It's talking about amount, it's talking about some pain, and it's talking about changes in stool. But that could be from a lot of different reasons. And so sometimes when you go in with these kinds of symptoms, the goal is to really like rule out other things that could be more serious, like, you know, like a tumor in your colon or something like that. And colon cancer is on the rise. So if you have not had your colonoscopy, another little plug, get it checked out. So you don't want to let things go, but oftentimes you can feel frustrated if you're someone who's been through the process of trying to figure out what's going on with your gut, and you keep getting told like it's not this, it's not this, it's not this. Well, the reason that we do it that way, or the reason the system is set up that way, is because it's really important to rule out the things that could be more serious first, and then down the road you may get an IBS diagnosis, right? But it's kind of like after all of these other things are ruled out, and we'll talk about what some of those things are. But it's major because it affects a huge portion of our population, like 10 to 15% of our population. So about 35 million Americans are affected. 800 million people worldwide are affected with IBS. And we have some different subtypes. So kind of more constipation dominant, more diarrhea dominant, mixed subtype, and then an unclassified subtype. And this is completely different. So IBS is completely different from inflammatory bowel disease, or IBD, which is a group of autoimmune conditions, including ulcerative colitis, Crohn's, and microscopic colitis. And so this is one of the reasons why it's super important. Like if you're having symptoms, get your colonoscopy done, because they will actually go in and like take a little biopsy to check for microscopic colitis, because we don't want to miss that, because it's super important. So even though the prevalence of these things, like the prevalence of these conditions is not high, like how many people actually have them, less than 1% of the population, but the health impact is really, really great. And so proper diagnosis is super important for your long-term health. And from my perspective, like from a nutrient deficiency perspective, we don't want to miss IBD, or we don't want to miss something like celiac disease, which is another autoimmune condition, because the nutritional impacts are really great, and we have treatments for them. So you want to be able to get to the right treatment and hopefully get there a little sooner. So your care team members for this would be a gastroenterologist and a registered dietitian. So the gastroenterologist to figure out and diagnose the IBD, and the diet and or celiac, and the dietitian to help with like, what the heck are you going to eat? Okay. I often talk about peeling the layers of the onion with my patients. Like, so often there are like multiple things going on with GI distress. So you may have a diagnosis of IBS. You may also have something else going on, like maybe you have stress-induced diarrhea. We know that in IBS, it is this disorder of gut-brain disruption, but also a lot of people in IBS have visceral hypersensitivity. So they're actually feeling the things in their gut more sensitively, like feeling that gas, for example, more sensitively than the same amount of gas in a person who doesn't have IBS. A lot of times there are dysmotilities going on, whether that's slow motility or super fast motility. Sometimes we see gut microbiome imbalances. Definitely dietary triggers. Of course, those are some of the things I'm looking for. Infections in the gut. And actually there is a specific type of IBS called post-infectious IBS, where it was caused from a foodborne illness. Like you got a bug, you got a bacteria, and ever since, like that was the start, that was the trigger. And ever since, things have been different GI wise for you. And some of my patients actually know that, like they can remember, but sometimes it's hard to remember, like, oh yeah, I've been sick a couple times. I don't know if that was the trigger or not. There actually is a blood test to check for post-infectious IBS. These days, it's called the SMART IBS test. So if you're curious, you can look into that. So these disorders of gut-brain interaction, it is a group of disorders classified by GI symptoms related to these things listed here. Any combination of motility disturbance, hypersensitivity in the gut, altered mucosal and immune function, altered gut microbiota, central nervous system processing. And so we're really starting to understand now that there is this bi-directional highway between the gut and the brain. They're always talking back and forth via chemicals, chemical signaling, and that they affect each other. So the gut can affect the brain and the brain can affect the gut. And you can see how it can get to be like a very vicious cycle. So especially for people who have had like maybe you've had some really traumatic events with your GI where you've had like some incontinence or something in public. So then anytime you get a little bit of a rumble out in public, you're like, oh no, is this the start of something? And then that stress in the brain can actually cause more symptoms. So there's actually gut-directed hypnotherapy for this, and there are psychologists now who specialize just in gut health. So they're GI psychologists, which is kind of amazing because that GI stress cycle is a real thing. So you can kind of see here, you get a little discomfort. We get those automatic negative thoughts. They're called, in the kind of mental health world, they're called ANTs, or ants. They're like little ants that run around in your brain, and they're automatic negative thoughts we have. They might not even be true, but they're there nonetheless. And sometimes we believe our own stories that aren't even true. So how do we change that? How do we calm that down? How do we change it to positive thinking? That affects our emotions. The emotions affect our sympathetic arousal. Then all of a sudden we're in that fight or flight side of our nervous system, and the worsened GI symptoms then cause more discomfort. So you can see it's that vicious cycle. And we do have really good research showing therapies like cognitive behavioral therapy work for calming this down, diaphragmatic breathing, meditation, mindfulness. So I mentioned the GI psychologist, other members of your team, like your regular counselor or your therapist, sometimes a psychiatrist or someone who's actually going to be prescribing medications, because we actually know that with IBS, especially like SSRIs and SNRIs, can be helpful with changing some of the chemistry that is involved with this cycle. So for some people, that's really helpful. Okay, let me just check. Looks like we don't have any questions yet. Okay. So I mentioned gut-directed hypnotherapy. This is actually really well studied over the past 4 decades. And it's kind of interesting in that it is as effective as a low FODMAP diet, which we'll talk about that in a minute. But it lasts a lot longer because with a low FODMAP diet or like medications, you have to be on them for them to work. While gut-directed hypnotherapy, for 80% of those people who experience improvement in symptoms, the improvement lasts for years into the future, which is just amazing. It's basically just trying to get the body and the brain to calm down, get into a relaxed state, and really work on some of that like gut-brain interaction, calming that back and forth down. There are professionals trained in this, but also there are apps out on the market nowadays. The one that I often refer my patients to is Nerva app, and that should be in our resources at the end here. So we'll mention that again. The caveat with this though is like if you are doing any sort of like, meditation, deep breathing, things that kind of calm down your nervous system, if you have more significant things going on, like, significant depression, anxiety, trauma, ideally you would be working with your regular therapist on those things first. So don't just skip right to the gut stuff and miss the big things. Okay, food wise. So we have potential for lots of different kinds of interactions that can cause issues in the gut, cause distress. I think of them kind of in these buckets. So intolerances, where basically you are not breaking down the food as well because of a lack of an enzyme or a lack of bile. So for example, in the case of lactose intolerance, there is a lack of the lactase enzyme, which is actually an enzyme made in our brush border. So in the villi of your gut, where you've got all that extra, the extra surface area and you're making enzymes there. So I mentioned earlier that sometimes with celiac, we see a secondary lactose intolerance because with celiac, if you've got blunting in the gut of those villi and you're not making that lactase enzyme, then all of a sudden, a lot of people will also have issues with dairy, like with lactose, when they don't have a true, like, intolerance necessarily from like a genetic sense, but it's an acquired intolerance. So sometimes when we treat the celiac and you get the gluten out of the diet and you start healing and regrowing those villi, then all of a sudden people will be able to tolerate more lactose. But other substances too, fructose, fructans, polyols, those are all in the FODMAP category or fermentable carbohydrate category. Fat, especially if you lack a gallbladder or you've got stones or sludge or something going on with your gallbladder. Histamine is another enzyme, another thing that is affected by enzymes in your brush border. So you make an enzyme called DAO in your brush border of your villi, in your gut. And so if your gut is inflamed or something's going on with your gut, you may not be making as much of that DAO, and then you can have a secondary histamine intolerance. So you may be familiar with histamine in the sense of like environmental allergies. Right now, we've got a lot of pollen going on. It's springtime. So if you've got that kind of environmental situation already happening, we've got a lot of histamine response already in the body, and then you have something going on with your gut that causes inflammation or causes you to not make as much of that DAO enzyme, then all of a sudden when you eat food, a lot of food has histamine in it from the bacteria making it, you could have an overwhelming histamine load, and then all of a sudden it's affecting your whole system. So histamine intolerance is a real thing, but it's often like a secondary thing to something else going on more foundationally in the gut. So we would want to figure out what that is. There is a intolerance to sucrose. There's actually a genetic predisposition for this. We'll talk about that a little later. Allergies, you could actually have a true like IgE mediated allergy. Like here are the top 9 most common ones, and then I added corn as well. You could have an autoimmune condition like celiac. One caveat with the celiac, so a lot of times people will start thinking, oh, I'm reacting to wheat, so they start cutting it out of their diet. But you really need the gluten, which is in wheat, rye, or barley, in your life to get an accurate diagnosis. And we really do want to know, like, is it celiac or is it something else? Because if it's celiac, then it's super important to get every single molecule of gluten out of your life, even like cross contamination and, being really strict and stringent about it. But if it's not celiac and it's something else, then we got to figure out what is that something else. So in order to have an accurate diagnosis, you need to keep the gluten in your diet until you get that testing done. And they're both like a screening, a blood panel screening, and then the gold standard is a biopsy from top down, so an endoscopy biopsy. There are also some sensitivities, so non-celiac gluten sensitivity, so celiac has been ruled out. I will say with a lot of these people that it's actually, people think that it's gluten that's doing it because they associate that with wheat and because gluten is such a buzzword these days, but it's actually the fructans in the wheat. It's actually the fermentable carbohydrates in the wheat that is causing the issue. So figuring that out takes a little sleuthing. Some people have sensitivity to nightshade family, like tomatoes, peppers, eggplant, potatoes. And really the gold standard with this is an elimination diet and working with your dietitian, to look at symptoms and look at, typical signs and symptoms, but also like pulling it out, putting it in, and reproducing that, like being able to reproduce those symptoms, not just one time, but into the future. And then also working with an allergist. If you suspect an allergy, that's a big thing to know. Sometimes, we think about allergies as like, oh, I'm going to, have my throat close up, or I'm going to have hives or something like that. But actually, some people don't have much reaction, but they actually do have an IgE allergy to one of these things. Like I have a friend who has an allergy to wheat, an actual diagnosed IgE allergy. She eats wheat all the time, has a cough as a result of it. Not, it's not great for her health, but she's not like having anaphylaxis. So it's, good to know because maybe there's something else going on, but if we know it's an allergy, then it's nice to know so we can cut it out ideally. It's not causing more inflammation. Okay. So, this is a lot, right? This is a lot to think about, and figuring this out, I would definitely reach out to a professional to help you work through some of this, because, even just the gluten versus fructan thing, like that is an easy thing to get mixed up. So also thinking about like this onion approach, like, there's oftentimes multiple things going on. So this was just one example from a clinic who looked at their patient population. So they're people with IBS. There was 186 patients that they had undergo some testing to look for some of these food intolerances. And 38% of their IBS patients, this was specifically their IBS D, so diarrhea dominant patients, 38% of them had fructose malabsorption. And almost half of them had fructan malabsorption. The fructans are in things like wheat, onions, and garlic. And then 22% tested positive for both. So oftentimes there are like multiple layers of things going on. So we want to, get to the bottom of it, because if you know that you have a fructose malabsorption, well, then we can look at your diet and say, let's cut down, the most high fructose items, see how you do. Not that difficult once we figure out what it is. So the fructose and the fructans are part of this category called FODMAPs, which is an acronym that stands for fermentable oligosaccharides, disaccharides, monosaccharides, and polyols. They're basically just all fermentable carbohydrates. And it's confusing. It's so confusing because there's so many good, healthy foods that are highly fermentable. And for most people, we actually want those in our diet because they are feeding your good gut bugs. They're feeding our probiotics in our gut. But for some people, you may not be breaking down the FODMAPs as well, or you may have something else going on, like too much bacteria in the wrong place, and then they're feeding on those fermentable carbohydrates. So for some people, the high FODMAPs can cause a lot of bloating, gas, pain. So take a look at these lists. Things like apples, super healthy, but highly fermentable. I already mentioned the garlic, but also things like mushrooms, certain nuts like pistachios, cashews, definitely beans because they're so high in fiber, milk and ice cream because of the lactose, wheat, rye, and barley, not because of the gluten, but because of the fructans in there. And then our low category, lots of other healthy foods. But yeah, it's not an intuitive diet. It's not an intuitive approach. So you really want to work with somebody, and you don't want to over restrict if you don't need to, which leads into these different approaches. So a low FODMAPs diet was never meant to be like a long-term solution. So if you were like handed a handout on this in an office somewhere, even a medical office, and said, hey, follow this, you should know it is not meant to be a long-term diet. It's meant to be a short-term trial. And if you feel better, then we need to actually figure out which FODMAP you having issues with. Because usually there's like one or two that people have an intolerance to. It's not all across the board. And we know that a low FODMAP diet is not great for people who already have restrictive issues, maybe people who have been chronic dieters or who have eating disorders in their history. And it's not a nutritionally balanced long-term plan. So if you've been on it forever, which sometimes people go on it and then they feel so good, they're like, oh, I don't want to mess it up. I don't want to go off of this. And I totally get that. But we do want to do some challenges in order to see like which ones are you maybe having issues with, which long-term means which ones can we expand in your diet. If you don't have issues with fructans, maybe we can expand and you can have some garlic again and enjoy that. So we're just trying to get back to, as much of a non-restrictive dietary intake as possible. So 3 phases: elimination, challenge, and then that personalization where we figure out not only what you can tolerate, but how much can you tolerate as well. Really important to go to that second and third step. Don't stay at the elimination phase. Okay, so that was a little primer on FODMAPs. I will say, like, it's so complicated that, really we could spend a whole day talking about it, which is why you go see your dietitian. Have an individualized session or a couple. Okay, let's talk about fiber, because we know most people are not getting enough fiber. And actually, sometimes this is the only thing you need. A lot of my patients who come in with digestive complaints, maybe I'm seeing them for something else, like diabetes or kidney stuff, but they're like, oh, my stooling isn't quite right. A lot of times it's just fiber that we need to put in there. Fiber is basically the indigestible part of the plant. It's only found in plants. So you're not going to find this in your dairy or your animal products. It is the cellular structure of the plant. So it's only found in plants. We don't have the enzymes to break the fiber down. So even though it is technically a carbohydrate, it doesn't turn into sugar in the body. So one type of carb that we don't turn into glucose. So, when you're looking at your labels, for example, and you're looking at that total carbs, the fiber is part of that total. So if it says 20 grams for a slice of bread and 5 of it is fiber, really only 15 of it is turning into glucose in the body. So the higher the fiber, the better the deal. But the fiber feeds your microbes, which is a good thing for most people. But if you are having dysbiosis, like you've got an imbalance in your gut microbiota, or let's say that you have too much bacteria in the wrong place, which we'll talk about small intestine bacterial overgrowth in a minute here, then sometimes the fiber can actually cause some worse symptoms. But for general stooling, general bowel health, and moving along that detox pathway. So stooling is one of our major ways that the body detoxes. So we really want to be stooling on a regular basis, and the fiber helps bind up some of those toxins that we're trying to remove from the gut. So super important. There are 2 main types of fiber. We've got soluble and insoluble. The soluble is the type that gels up in water. It absorbs that moisture, makes your stool softer. It can slow down the movement through the gut a little bit, but it is used for both constipation and diarrhea, because a lot of times in constipation situations, things get so dry that the soluble fiber helps to keep moisture in there in order to be able to pass that stool easier. The soluble fiber is the type that is fermented by our microbes. So that's the type that's really going to feed your good gut bugs. So it's really important to keep in your diet as much as you're able. Some soluble fibers are more fermentable than others. So for example, my little note at the bottom of this slide, many people can tolerate psyllium fiber, which is the fiber that's in Metamucil. So psyllium fiber is highly soluble, but it's not very fermentable. So that's why it's often recommended for both constipation and diarrhea, because it's going to help absorb that liquid, make stool softer, but it's not going to cause a lot of fermentation, so not a lot of extra gas and bloating for people. When you think about insoluble fiber, insoluble is like the bulk. It's the stuff that doesn't mix in water, doesn't gel up. It speeds things through the GI tract. It can be a little bit of a GI irritant, so it helps kind of increase that mucus production to move things along. And this is really like the skins of things, like the roughage. So if you think about an apple, the outside skin of the apple is that insoluble fiber, and then the soluble fibers are on the inside of the apple. So there's usually a combination in most of our foods. Okay. I don't think, let me check the Q&A. Can we get a recording of this webinar? Absolutely. Stilly Valley will send you a recording and these slides afterwards, so you can go back and review it. Okay, so the average US intake is around 15 grams, but the recommended intake for women is 25 grams or more, and for men is 38 grams or more. Basically, that is based on your calorie intake. So it's about 14 grams per 1,000 calories per day. So, guys tend to need more calories than gals on average. So that's where those differences come in. But basically, the point is we're not getting enough. We're getting maybe a half or maybe a third of the recommended fiber intake per day. This is, US adult data. One thing with fiber that I hear from my patients are like, oh, I tried adding the psyllium, or I tried adding chia, or I tried adding the fiber, and it just made things worse. So with fiber, the name of the game is to go low and slow. So you really want to allow your GI tract and your gut microbiome, so all those little microbes that are feeding on the fiber, you want a little bit of time to adjust. So the recommendation is you increase this slowly over time and make sure to increase your fluids. So we're looking at like 3 to 5 grams per week, which is, not very much. It's like a little teaspoon of extra fiber per week, with the caveat that you've got to have the fluids there as well. If you throw more fiber at an already constipated situation and you don't increase your fluids, you're going to make it worse. So, be careful with that. Okay, what else? So I've got this little 30 icon on the page here because there was some research looking at individuals who had the most variety. So like the best microbiome, variety in their microbiome of different beneficial bacteria. And what was seen is that people who had over 30 different plants in a week had this better diversity in their gut microbiome. And so, if you think about how many plants you ate today, I've had quite a few. So, because I had a stir fry for lunch, there was some tofu in there, there was some brown rice, of course, the vegetables, I added the sesame seeds. So even right there, I had like, I don't know, 7 different plants. So this is doable. 30 sounds like a lot, but it's actually quite doable. If you're not getting the variety, because sometimes we get stuck in a rut, right? Like we just keep eating the same things over and over. If you're not getting the variety, this would be a good goal. That 30 plants per week, write it down, start adding up your plants, see how you're doing. And I would say, in addition to different plants, because all the different plants have different fibers, try and get that rainbow of color so that you're really getting those different micronutrients, your vitamins, your minerals, and the phytonutrients, the colors in those plants, which we know are associated with different health benefits. So I'm going to clear this question. Okay, great. Fiber rich but low FODMAP food. So if you're having a lot of bloating, gas, maybe you know that you need to be a little bit lower on some FODMAPs. Some really nice high fiber things to try, like kiwi, oatmeal, raspberries, chia, oranges, carrots. And the low FODMAP diet, I don't think I actually said this, but it is the gold standard dietary approach for IBS that we have right now. And again, it's not meant to be, it's not meant to be like a long-term thing. You don't stay on it, but it can provide a lot of relief for people. And then we can figure out, which FODMAPs can you actually tolerate. Okay, let's talk about supplemental probiotics. Probiotics are all over. You can even get them at like some of your gas stations these days. Like there's probiotics in our soda, and there's probiotics in our granola bars, and there's probiotics in our gummies, and there's probiotics just everywhere. So just as a basic information, like what is a probiotic? A probiotic is it's a microbe, could be a bacteria, could even be like a yeast, but it's been shown, something that has been shown to have benefit in the research. So there may be things out there that aren't necessarily yet called probiotics that are healthy for us. We just don't have the research to call them probiotics. But it's something that gives the human host a benefit in a certain amount, like in a therapeutic dose. And what we know now is that the strain matters. So it's not just like talking about genus and species, like So lactobacillus would be the genus, the species would be plantarum, but it's even down to the strain level. So this one is 299B, where the different gut bugs are doing different things. So we can't just lump them all together. You can't just say, oh, all lactobacillus do X or all bifidobacterium do Y. We know that even down to the strain level, they do different things. And so this is partly why, it's so complicated and there's so much more to learn, because even within the same species, they're having different effects. Right now, with where our research is at, the American College of Gastroenterology for IBS management is saying, like, we don't have enough information. We can't really make a guideline right now, but definitely talk to your gastroenterologist or your dietitian or even your primary care provider, because we do have some research on specific strains for specific conditions like diarrhea or constipation or after an infection of C. diff. So, if you have questions about that, reach out to your providers. And here are a couple resources for you as well. So these are online guides to that basically are collating the latest research on these different strains to kind of put all the information in one place. You can quickly go there and see, like, what data do we have to support Lactobacillus plantarum 299B for diarrhea, for example. So I'll give you some more details. Okay. So a lot of the things we were just talking about is really related to, like, kind of that IBS symptomology. Now, there are a lot of other things that could be going on. So I will send you this handout afterwards. So you'll get this with the recording and with the slides. I'll have Stilly Valley send it to you all. Because there are things that can present and look like IBS, but are not IBS. So we've already talked about celiac and IBD. You could have a GI infection, a parasitic infection. You could have bile acid malabsorption, small intestine bacterial overgrowth, histamine reactions, sucrase isomaltase deficiency. So this is that I mentioned sucrose earlier, how some people have intolerances to sucrose. This is actually a congenital condition. So it's actually something that people can be born with. It's a genetic trait. So for people who have had, like, chronic loose stools, chronic diarrhea their whole life, this could be going on. And in fact, I have a patient in my schedule right now who has CSID. We just figured it out. In a patient population, this was just presented at Digestive Disease Week this year. There is a clinic who looked at their patient population and did a study on how many of their IBSD patients have sucrase isomaltase deficiency. And it was like 8%. It was like quite high. We did not think that many people, I mean, it's not 8% of the total adult population, right? But of the IBSD people, that's quite a high amount. So if we could figure that out and know, like, oh, this is the reason for your IBS or for your diarrhea, then there's an easy enzyme that you can take that will just make your quality of life so much better. So it's not an easy thing to figure out necessarily, like you have to do some sleuthing, but it's a really easy thing to treat. So, worth doing that sleuthing. I already mentioned the pelvic floor dysfunction. Some people actually have systemic nickel allergy syndrome, which can look very much like IBS. So I'll send you that information on that. Intolerances, like carbohydrate intolerances, like lactose, fructose, fructans, polyol, sorbitol, for example. And then the exocrine pancreatic insufficiency, which is also an easy thing to address with digestive enzymes. Both we have both over the counter, but if you have true EPI, you would get that as a prescription. Okay, so a lot of different things that could be going on. This week in my patient population, I saw all of these except for Giardia. He did not see an infection, which is, that's pretty normal, right? Like we don't see a lot of infections in the United States with parasites, but if you've been out of the country, or even if you've been like to the upper Midwest, like to Wisconsin in the summer, for example, and you were in a lake or a stream or a river, and then you came back with some GI stuff, it may be Giardia. So it is around. It's just not as common as some other places in the world. Okay, so I said we were going to talk about SIBO and EMO, so let's do it. I see a lot of patients with SIBO and EMO, and they oftentimes come in presenting as just IBS, but we know from the research that, and this is still like being elucidated, we're still figuring out what the true number is, but somewhere between like 38 up to 70% of people with IBS may be diagnosed with IBS, but actually have small intestine bacterial overgrowth or intestinal methanogen overgrowth. So it's really worth checking out. And nowadays we have a non-invasive breath test that you can do to look for this. And you're looking for 3 gases, hydrogen, methane, hydrogen sulfide, any one of those 3 or multiples. A lot of times people have multiples. Can be causing, the symptoms: bloating, gas, diarrhea, nutrient deficiencies. Sometimes that's actually how I catch this, is like people come in with some GI symptoms, they're not feeling great, and then they have like low B12 or low iron, and they're eating, foods with those things in them. They don't have a GI bleed. They're, otherwise like they should have really good nutrient stores, but we check their iron and it's low, or we check their B12 and it's low. And it can be because these bacteria, or in the case of methanogen overgrowth, it's really an archaea, which is like an ancient bacteria. So it could be bacteria or archaea basically using the nutrients, and then you're not getting the nutrients. So the classic thing that I see with SIBO and EMO is bloating. So bloating is like the hallmark symptom. And typically the bloating gets worse over the course of the day. Like basically every time you eat, you're putting a little something into the bucket. And then by the end of the day, the bucket's overflowing with symptoms, AKA gas, because the microbes are feeding on those, especially those FODMAP foods, those fermentable carbohydrates. We do have treatments for SIBO and EMO, 3 main treatments: antibiotics, herbal antibiotics, and elemental diet, which is a completely broken down liquid diet, broken down into its elemental parts. So like not proteins, but amino acids. All 3 have some research behind them. And sometimes we need actually to use all 3. Like some people respond better to one of these treatments than the other. And sometimes it takes multiple rounds or multiple different trials to get this under control. But the deal with SIBO and EMO is we always want to figure out why. Why did this happen in the first place? Because it's a secondary diagnosis to an underlying motility issue, or like something going on that's affecting that movement in the gut. Risk factors would be like pelvic floor dysfunction, which we've already talked about. Adhesions, which is like scar tissue in the abdominal cavity that can actually cling onto the GI tract and kind of pull it out of whack. So if you've ever had like abdominal surgeries, serious like car accident, for example, where the seatbelt went and like caused damage across your abdomen, pregnancies, cesarean sections, endometriosis, like high, inflammation in the abdominal cavity. Any of those things could be causing adhesions, and we have treatment for that. So there are massage therapists and also physical therapists who are specialized beyond their general training. They're specialized in VMT, or visceral manipulation therapy, which is meant to like get in there and kind of figure out what is going on with that scar tissue and help to break it up without making it worse. So it's really important to have somebody who knows what they're doing with that. And you can just, search that, visceral manipulation therapist. Other things that could be risk factors for overgrowth, biochemical things like low thyroid, low stomach acid, low pancreatic enzymes, low bile. Those are all things that we could potentially address and could, get the motility piece going better, as well as killing. Like in this case of low stomach acid, if your stomach acid is low and you're not killing the bacteria coming in, we need to work on the stomach acid so that you're actually able to kill that bacteria. Foodborne illness, we already talked about, that's that post-infectious IBS situation. And then neurological disorders. So for example, my patients with Parkinson's or with a spinal injury, or something neurological going on. And actually now, so I put down here gastroenterologist as your health care team member, but we actually have now neurogastroenterologists who are even more specialized for conditions like Parkinson's, for example, where it is a neurological condition, but it's having a significant impact on the GI tract. So there's even like specialists within specialists. So, don't let these things go. Like, we want to figure out what's going on, because in the case of like an overgrowth situation like this, it's treatable. And we also want to get to the root cause, like, why did this happen in the first place? And those things are also treatable. It might take some time and it might take some sleuthing, but totally worth it for your quality of life. And we don't want to just let GI things go, because they really do affect your long-term health. They're affecting your long-term nutrient absorption, your long-term risk of things like heart attack and stroke and dementia. It matters to get this rest. So, okay, let's consider, all these layers. There might be multiple layers for you depending on what's going on. It might not just be one thing. It's usually more complex than that, and there may be multiple things going on. So if you are trying some stuff and you're not like 90% better, please do get help. Reach out to some of those providers that I mentioned. There's a lot of different avenues to be, sleuthing, like the physical therapist, the psychologist, the gastroenterologist, the allergist, the dietitian. Yeah, a lot of different support that you can be getting. I would keep a food journal, or even better yet, a symptom journal. So instead of like writing down all your food, which is exhausting, keep a symptom journal. So just write down the things that you had when you have a symptom. So if you go out for dinner, you go to a restaurant and you're like in the bathroom before you even leave the restaurant, that's a good meal to write down. Like, what happened there, right? Not just like what you had, but the amounts as well. Maybe what the situation was it super stressful? What was going on there? Because when you bring that into your dietitian, we can look at it and go, okay, we think that this is, for example, a fat malabsorption situation because it happened so quickly. Let's add this up and see, like, how much did you have that caused the symptom, right? We can get that dialed in for you. So that symptom journal can be really helpful. Please do not stop your medications or treatments just because you feel better, right? Oftentimes you feel better because they are working, so you want to stay on them. So for example, if you need digestive enzymes, keep taking them. They're working. That's why you feel so good. Do you take a big picture approach? Like sometimes you just need to zoom out and be like, okay, let's look at the big picture. Maybe even start over. Maybe you need like a second set of eyes. Maybe you need a second opinion on something, because the answers are out there, but it might just take a little bit of digging, and it might take some time to find the right person to help you do that. But hopefully this today and the last class gave you some ideas for building your team of healthcare professionals. And we're going to talk about resources in the next 1 minute that we have left. But before I say that, any of these red flags, do reach out to your provider right away. Bleeding, difficulty swallowing, new diarrhea, tachycardia. So yeah, if you're feeling way worse, get help right away. Okay, here are your resources. So we have some GI general information, or if you're looking for a gastroenterologist, if you're looking for a registered dietitian in your area, you can go to eatright.org and also see kind of what areas they specialize in. If you're looking for a GI psychologist or a therapist who knows about gut health stuff like CBT for gut health or gut directed hypnotherapy, here's a couple websites. Here are here's that Nerva app I mentioned, a couple resources for gut directed hypnotherapy. If you're looking for a pelvic floor therapist, you can look at these sites. You can also ask for a referral from your primary care provider. Here's a visceral manipulation therapy database for searching either by your zip code or by your city to find someone who is specialized in VMT, so working on those adhesions in the abdomen. Some toilet accessories like Squatty Potty and Hello Tushy, IBS support. Some books that I have really enjoyed. These are, two of these are by dietitians, and one is by a gastroenterologist who is also a researcher. Bathroom apps, so that you can always find a restroom near you. If you think that you need to go the low FODMAP route, I would highly recommend the Monash University app, and they do a really good job with a red, yellow, green light system for their FODMAPs, and it can get like personalized for you. Behavioral apps, there's a few there. Regulora is actually FDA approved for IBS. And then some breathing and meditation apps, which can be really, really helpful for people. So I know this was a lot of information. Do stay hopeful. Do stay curious to figure this out for you, because it is a major quality of life and long-term health scenario. And hopefully you will get your team and you will, develop those people around you to figure out your situation. You can always reach out to me. There's my contact information. And hopefully I'll see you at a future Stilly Valley class, maybe in person or at a virtual class in the future. And I wish you the best gut health. All right, happy spring, everybody. Take care.